I'm Laura van Gennep. I'm a medical student from the University of Groningen, and I'm going to tell you something about research I've been doing on the Department of Anesthesiology. And the name of the study is a randomized study comparing 3 bronchial blockers, ARNT, QDEC and IZ blocker, and a double lumen tube for lung isolation, a mannequin study. I'll start with an introduction. In most cases of thoracic surgery, oh, I'm sorry, the picture is lost. So I'll try this. Er zat nog een blaadje in, maar kun je die Yes, thank you. In most cases of thoracic surgery, one lung ventilation is necessary. And in one lung ventilation, one lung is isolated, and when it's isolated, the lung will deflate, so the surgeon is able to operate on this side of the thoracic cavity or this lung without perforating that lung, while the other lung is still ventilated, so the patient won't get hypoxic during surgery. There are several devices to achieve one lung ventilation, and the most used device is a double lumen tube. And you can see a scheme of the double lumen tube over here. A double lumen tube consists of 2 lumina. One lumen ends halfway the trachea, and you can ventilate your patient through the tracheal lumen. And you can isolate this lung with the bronchial tip, and you have to inflate the cuff at the end of the bronchial tip to isolate this lung and let it deflate. This is the most used device, but there is one big disadvantage. The double lumen tube has a very large diameter, and this is a small double lumen tube, and this is a very big single lumen tube. And you can see the diameter of this one is much bigger than this one. And because it's that big, it causes much damage on the tracheal epithelium. And other devices that are used to achieve one lung ventilation are bronchial blockers. When you want to introduce a bronchial blocker, you have to intubate your patient with a single lumen tube first, and it has a smaller diameter. And then you have to introduce your blocker. You can see there are adapters at the blocker. You can put that on the top of your single lumen tube. And as soon as the adapter is in position, you can go on ventilating your patient. So it takes about 10 seconds to ventilate your patient again. And then you can pull in these wires with at the end the tips, and you can see a detail of the tips over there. This blocker is the IZ blocker. It consists of 2 tips. One tip has to be placed in the left main bronchus and one has to be placed in the right main bronchus. And you can inflate one of the cuffs, whether it's depending on which lung you want to isolate. And this is the ARNT blocker, and this is the QDEC blocker, and it has a hockey stick-like shape. And all these blockers have to be positioned under guidance of a bronchoscope. There's been doing much research on the double lumen tube and the ARNT blocker, but never they compared the IZ blocker and the QDEC blocker. So that's what we wanted to do. And this was our research question. Is there a difference in time needed for introduction and success rate between the classical double lumen tube and the 3 bronchial blockers? 20 anesthesiologists participated in our study. They had to intubate our mannequin with a double lumen tube and the 3 bronchial blockers. So each anesthesiologist intubated 4 times, and they had to isolate the left lung. So the bronchial blocker or bronchial tip of the double lumen tube has to be placed in the left main bronchus. And we recorded the time that was needed for introduction and the success rate, and we checked it by a bronchoscope. And you can see a picture over here from what you're seeing when you use a bronchoscope. You can see here the carina and the right main bronchus and the left main bronchus. And this is the QDEC in the right position, so in the left main bronchus. And these are our results. Over here you can see the time that was needed for introduction in seconds. As you can see, double lumen tube took only 10 seconds to introduce, so it was very fast, significantly faster than the bronchial blockers. There were no significant differences between the blockers. But because you can ventilate your patient as soon as the adapter is attached to the single lumen tube, it is clinically an unimportant difference, because the patient stays unventilated in both cases for about 10 seconds. But the success rate is more important, and you can see the blockers were more successful than the double lumen tube, and the ARN was the least successful bronchial blocker. And the EZ blocker and the QDAC blocker was successful in all cases. Well, when the double lumen tube wasn't in the correct position, it was because the bronchial tip was placed in the right main bronchus instead of in the left main bronchus, or the tip was placed too deep. And malpositioning of the ARN blocker also consists of positioning in the right main bronchus instead of in the left main bronchus. So, the conclusions we draw. First, introduction of the double lumen tube is much faster than introduction and positioning of the blockers, but because this is clinically unimportant, as I told you, and the success rates of the EZ blocker and the QDAC blocker were significantly higher, the EZ blocker and the QDAC blocker are preferable to both the double lumen tube and the ARN blocker. Well, some future perspectives. We already started a cadaver study, and yeah, that's still going on, so we don't know what's happening in that study. And if the results of this study are also promising, we want to proceed with a randomized controlled trial in real patients, so we can do some recommendations about which device should be used when you want to achieve one lung ventilation. And I want to say thanks to Anne Ekema and Nieuwenburg Group for giving me the opportunity to participate in their research. Okay. Are there any questions?
Were all of the anesthesiologists equally experienced with all of these devices?
Well, we asked experienced anesthesiologists and also anesthesiologists who weren't experienced, so we had a mixed group. So it gives a good reflection of the anesthesiologists that are working at the surgery department.
All four of the techniques were about equally practiced and experienced?
Yes, most anesthesiologists have seen the double lumen tube, some have used them, but none of them had ever seen a blocker, so they didn't know how to use it. So that was equal. Any other questions?
When you say that they've never seen a bronchial blocker before, so they're not used in practice?
Well, not that often, because the double lumen tube is used mostly, and we asked all kinds of anesthesiologists, and only cardiothoracic anesthesiologists sometimes use those devices, so yeah, they're not that well known.
So what are the indications to use one of those in practice at the moment?
Well, for thoracic surgery, so when you have to operate on one lung or operate on one side of the thoracic cavity, so for FATS procedures, video assistant.
So they always used rather than a double lumen tube?
Yeah, most of the time, and sometimes an ARN blocker, but the anesthesiologists that participated in our study never had used an ARN blocker.
So they got a 100% success rate despite never using it before?
Yes.
It's because of the way you use it. You introduce the blocker using videoscopy. So you see on a picture what's happening, and then you move it forward and try to put it in the right place. With two of those devices, it's not so very easy to prove the study, and the other device, it's far more difficult. And that's similar to clinical practice, and also similar to a few studies who use the ARN blocker in patients. They always demonstrate it's not a very easy device to use.
So there have been studies
in patients, there have been some studies using the ARN blocker, but not the other two blockers.
Okay.
So So that's why we started to do this in a model, and then from the model we go further to the patient. The first presentation was about learning. Do you have ideas about using this mannequin model for training of anesthesiologists and residents in the use of bronchial blockers?
Yes, the anesthesiologists that participated in our study, they were very positive about these mannequins. They said it was almost like the normal situation. So it is a good way to practice it, and then you can go on the real patients. But then you have practice it sometimes, and hopefully for the patients it goes more successful.
So we have to talk to the speaker. Okay, thank you very much for the presentation, and now for a brief moment we discuss